Thank you, Virginia, and thank you for your patience as I got connected here. This is a photograph from Calcutta, India, that shows residents of an informal settlement waiting to collect water for their household's daily needs by standing in line. This effort to collect essential water is a major daily task for many low-income households globally. Indeed, UNICEF estimates that women and girls spend 200 million hours each day collecting water. And this has a cost. Amy Pickering and Jenna Davis, working from Stanford, analyzed 200,000 demographic and health surveys across 26 countries. And they found that a 15-minute decrease in one-way walk time to water sources was associated with a 41% reduction in diarrhea prevalence. And in addition, an 11% reduction in mortality among children less than 5 years of age. So ready access to water for the household means a lot for child health and even for child survival. A very influential review by Steve MCHRI and his colleagues back 3 decades ago noted that in 14 of 15 reviewed studies, increased access to water, that is, increased water quantity, was associated with decreased diarrhea and other adverse health outcomes. They also noted that the amount of water used was more important than its source. And this idea that quantity of water was more important than water quality actually got a lot of attention. And so a few years later, Sandy Cairncross from the London School of Tropical Medicine and Hygiene articulated what was an increasingly common perspective, that water quantity has a more important impact on improved health than water quality. And as this thinking became more and more widespread, people started to ask whether water quality really mattered at all, whether this was really all about water quantity. So in this systematic review by Gundry and colleagues, they concluded that for diarrhea, there was no clear relationship found with point of use water quality. That is, when they looked at indicators of fecal contamination, it was a pretty messy signal and they couldn't see a clear relationship. Well, to some of us in the field, this just seemed odd. You go back in history, for example, and you look at cities that had water supplies that were located near sewage outlets that then improved their water supplies, and they had a marked reduction in gastrointestinal mortality. This indicator is typhoid fever deaths. And you see across many cities, yes, over a century ago, there was a 78% reduction in typhoid mortality when you stopped having fecal contamination in the water supply. So one approach then has been to say, well, we certainly need water quantity, but we might be able to improve water quality by adding low-cost bleach, sodium hypochlorite, with a special vessel that would make it hard to recontaminate the water, teach people to add water, add the bleach, and then only draw out of the tap. And so when Rob Quick first deployed this in Bolivia, now over 25 years ago, what he found was that households who were given this point of use water treatment reported 44% less childhood diarrhea. And this generated enormous excitement and a lot of variations on how water might be treated in households. And so you could imagine using the safe water system, the chlorine base that Rob Quick used, or biosand filtration, or solar disinfection, or filters, lots of different approaches. And eventually a lot of trials were done, and then meta-analyses were done. So you can see that there were different techniques for point of use water treatment. And you can see that there are a lot of trials being done with tens of thousands of people ultimately enrolled. And we also see a pretty consistent effect that if you treat your drinking water with interventions that would be expected to reduce microbiological contamination, then children would have less diarrhea. But there was a problem with this narrative. And the difficulty with this narrative was that the quality of evidence was not considered high, despite the fact that these were randomized controlled trials. For example, the data on chlorination were seen as low quality. So what's going on here? Well, the big concern has to do with risk of bias. That is, and particularly concerns with blinding. That is, if you give somebody a water filter or you give them a safe water system, and then you come back and say, hey, have your children had diarrhea? They're out of courtesy, they sort of know what you want to hear, and there is a risk that that report would be biased. And this is not just a theoretical problem. Wood and colleagues did a remarkable study of 146 meta-analyses. So they looked at meta-analyses that included over 1,300 trials and evaluated a range of intervention and outcomes. And they evaluated the difference in effects of these various interventions depending upon whether there was adequate or inadequate allocation concealment. That is, whether people were blinded or not to the intervention, and whether the outcomes were subjective, people reported them, or they were objective, they could be directly observed. And what you can see is that overall, studies here on the left side that had inadequately concealed interventions tended to be much more likely to report a positive effect. Similarly, studies that had subjective outcomes that were not observed, like reported diarrhea, were also much more likely to report a positive effect of the intervention compared to more objective measures like all-cause mortality. So this was a real threat to the argument that the point-of-use water treatment literature supported efforts to treat drinking water. And so then you start saying, well, wait a minute, is this just quibbling academic controversy? Why are we even arguing over this? We're arguing over this because over 500,000 children die of diarrhea year in and year out. So it's not just an academic controversy, it's a question of should we allocate resources to try to improve drinking water quality, or should we focus exclusively on quantity? I will say that my intuition is that self-reported courtesy bias likely did overestimate impact, but there was also probably a genuine effect. And the question was, how might we identify the hypothesized real effect from the bias? So I've talked a little bit about point-of-use water treatment. One problem we have with this is there's low uptake, especially among the poorest, most at-risk households. And they also, if we use chlorine, complain about chlorine tastes. So one approach that Amy Pickering and I have thought about is looking more at point of collection water treatment. That is, you don't just treat in your household's water, but if you could put this in where the community was using shared water infrastructure, you could leverage that, and so it would require no user effort, and then you could control the chlorine dose more. So this is something, how this would look is, so here this is an Aquaflow, which is a device that is one of these point of control devices. And you can see the water coming in, it progressively erodes the chlorine tablets. And so then there's chlorinated water in the shared tank, and people draw out of that tank. They don't have to do anything, they get chlorinated water. And this also allows us to optimize the chlorine dosing level, because Joschka Kreider, who is a postdoc now at Stanford, she was an undergraduate when she did this work. When we did taste experiments in Bangladesh, we found that people could detect pretty low levels of chlorine. And so we were interested in dosing at a level below which they would taste, and so that they wouldn't reject it based on taste. So we did a study in Dhaka, Bangladesh, with 2 urban communities who had intermittently supplied water, and we enrolled water points with water storage tanks that didn't have any current disinfection. So we did this with 100 water points that were randomized to treatment or control. And this was a blinded trial. Everybody got a doser. Each of the doser had a tablet in it. It's just that half of those dosers had chlorine tablets and half of the dosers had vitamin C tablets. That's water-soluble vitamin that we wouldn't expect to impact diarrhea. And we followed them up for 14 months. What you can see is that we were successful in adding chlorine to the taps, and that people who were who received the chlorine, over 80% of them had detectable chlorine, and at a mean level near where we were targeting. And this also markedly reduced the fecal contamination with E. coli, which is our marker of fecal contamination. So was the blinding successful? When we asked people, what do you think is the dosers adding to your water supply? Over 76% responded vitamins. And among the persons receiving chlorine, 70% thought they were receiving vitamins. A little more, the people who were receiving vitamins thought they were receiving vitamins. But by most standards, this was effective blinding. And what we see then is, depending upon the definition of diarrhea, we see about a 20 to 25% reduction in reported diarrhea. And even in a subset analysis of those who thought they were receiving vitamins, again, a 34% reduction in diarrhea among those who were actually receiving chlorine compared to the vitamin C. And we saw other benefits, including reduction in healthcare costs and antibiotic consumption. Then we took a second strategy to explore this impact of water treatment. And I want to go back to the meta-analysis and point out this notion of all-cause mortality was unbiased. It's objective. And many randomized controlled trials of water treatment have been conducted, but none of these studies were powered for mortality because it was too rare of an outcome. So we wondered whether it would be possible to review all available literature and estimate the impact of water disinfection using a meta-analysis. And it was really Michael Kremer, the economist, who suggested this approach. So we looked at randomized controlled trials from low and middle income countries that had child mortality data available, and we followed up with all the authors and got as many as we could. And what you can see here, this is the summary, is that children who were randomized to water treatment in these trials had a 32% lower all-cause mortality. So taking these data together, we conclude that multiple lines of evidence support that improving the microbiological quality of drinking water reduces children's illness and death. We argue that there is historical evidence of impact on child mortality with improvement in water supplies. We had a blinded randomized control trial that shows the impact on diarrhea, and a meta-analysis that is under review that improving drinking water also reduces child mortality. And so, as a policy, we urge that efforts to improve microbiological quality of drinking water should be supported. I would note that this work is really group work. The randomized control trial was led by Amy Pickering and Sonia Sultana, and the mortality meta-analysis was led by Michael Kremer and others who helped. So I hope that instead of perpetuating this tension between water quantity versus water quality, that we can come to a point of thinking about both water quantity and quality for child health. Thank you.
Great. Thank you very much, Dr. Luby. A very nice discussion of just research design in the context of impactful work looking at water availability and quality. I'd like to start with a question from one of the participants. For those that aren't familiar, what are the challenges to conducting international research in the global health setting?
Oh, there are no challenges at all. It's a piece of cake. It's just as easy as doing proteomics, right? All this is hard. All this is hard. I lived in Bangladesh for 8 years. I lived in Pakistan for 5 years. And so I think the key step in this is really understanding local context and really developing partnerships with people who are working with you. So, so I think that that's part of the hard aspect of being based at Stanford and really engaging substantively with colleagues. And it's really spending enough time in country, in place, to begin to absorb, to begin to see the world through the perspective of the target population. So I think that's the first step. And then there are a number of really practical issues that you have to work through. Actually teach a class on research methods in global health, practical approaches in global health, and feel free to check that out if you want to learn more.
Fabulous. And actually, now that you've put on your director's hat, let me ask a question related to that. How can folks partner with Stanford Center for Global Health to expand their research outside US and our campus?
We would love to have you, because there's just all of this opportunity for this rich interdisciplinary environment that we have here to bring the skills of people to help support this work. So a first step to do would be to go to the Center for Innovation in Global Health website and register, because if you register, then we can send out information to you regularly. We're holding our research convening in January. It's on the site. I'm not going to say the date off the top of my head because I'll get it wrong. And one of the main things we really want to do is to build a sense of community and to help people identify places who they can work with and connect. So one of the ways that's really important in terms of contributing to global health is to figure out what background you have, what skills you bring, and how those then can be leveraged to work. And even things that might seem as far removed as some of the machine learning that was talked about by Professor Agyapur, in fact, all of those are actually really important tools in global health as well. So it can be a very constructive conversation if you're interested, and we would love to have more people involved.
That's great. One of the listeners would like you to talk about other types of bias in global health settings that people may need to pay attention to.
There are lots of biases. There are, I think, of particular concern is that I see is selection bias in terms of who is our study population, who are we comparing them to, and what broader conclusions do we want to draw. So, for example, in the meta-analysis that I've shared with you, reviewer comments are concerned with saying, okay, you've got this handful of studies that you've done, but when you think about the diversity of children's experience globally, this is actually a pretty small sample of a few places in a few sites. And are you really able to defend the argument, the assertion that this is a more generalized phenomenon? And so that's this tension between the global and the local, that we are comfortable as scientists when we have something more controlled, like a randomized control trial or a study in our lab, but we have aspirations to draw inference more generally in terms of global policy. And so I think that that's another issue that we continue to struggle with. And just the confirmation, another bias I think that's big out there is confirmation bias. Is when we see something that accords with our intuitions, we like that. And it's harder for us to give the same amount of skeptical interrogation to it as when we get a result that surprises us.
Right, thank you. And then the next question is, what do you think accounts for the quantity hypothesis bias? And what I was hearing about quantity and trying to make sense of it, what came to my mind was dilution is the solution. It's better to have some water than no water for dilution. But is there a bias built within that data as well?
I think it's a great question. First is the data on water quantity is not nearly as strong as on water quality. And I didn't share that meta-analysis with you, but it's become a really common statement. Water quantity is more important than water quality. But if you actually dig down, there's not, the evidence base is okay. I think it makes sense. I think it makes sense because the more water you have means you also can spend more time washing hands and you can spend more time cleaning up. So I think that it likely helps on the hygiene side. And it also means you're not just so scarce that you're under allocating it. I also think that one of the reasons this bias comes about has to do with different types of professionals. A lot of people who work on water and sanitation are water engineers, are civil engineers. And so the idea of building water systems with pipes resonates with them. And those of us who are physicians who think a lot about pathogens and what are going in, we're thinking, I think we have a natural tendency to think, wait a minute, but what's in there? So I actually think that I think there is even an underlying difference in view of the worlds of different professions that contributes to this different these different conclusions. And so I don't. So I think what the important point is not to say water quantity doesn't matter. Obviously, it does, and it's a big problem because of increasing population density and fixed water supplies. But we really need to give quality attention as well, because that's an intervention that we can save lives with.
Great. Somebody else would love to get your input on what you think the hot topics areas are right now, I guess, in terms of global health.
I would say right now, the hottest topic is our issues around equity. Like we're in a global pandemic that killed so many people across South Asia, millions and millions and millions. And yet we have, and we have worked to set up a global system to detect disease. And we have not made the same commitment to work to address these diseases in low-income countries. And there are two problems with this. One is a deep problem of injustice. In addition, it means that we are not protected because we're not taking care of these issues globally. And if we do not reinforce our solidarity with people around the globe, then we can't really build the trust and build the institutions going forward for the kind of sharing that really supports all of global thriving. So I think that this notion across everything from child mortality to maternal mortality to COVID coverage, so many of these issues just keep coming up through an equity lens as being issues that are really of central importance and I would say are hot.
Great. I think that's a wonderful place to stop and a very important concept to let settle in to everyone. I do want to just highlight again the website, globalhealth.stanford.edu, for people who are interested and have been inspired to think more globally in the work that we do.